Thanks, Vicky, and thanks for having me today. So I'm originally from Tassie, but went to Sydney to do my training and never found it back here. But hopefully one day, and I like coming back just to have a few days with my family. So I'm going to provide just a bit of an overview of new things that are available for the different subtypes of breast cancer. And I guess what I'd say in advance is that I could talk about this for a whole day or even a whole week. And so it really is a lot to cover in a short time. And it's just really just to provide a bit of a flavour of what's new, what's emerging, and just a few more things to read about, I guess. So I apologise in advance that we can't go into a lot of detail. So first of all, I would hope that you would sort of understand that metastatic breast cancer is where the cancer has spread to another part of the body distant from the original site, so the breast or the lymph nodes. And it's, I guess we'd like to think of it now as being a chronic illness in that most of the time women will survive for many years, and I guess increasingly we're seeing the benefits of advances in treatment that are really extending the time that people will survive for, and I guess improve quality of life as well. And I think what's often a little bit misunderstood is that there are a couple of ways that people can present with metastatic disease or advanced breast cancer. And the most common is where someone has had early breast cancer in the past, and then there has been a recurrence after some time. And that's, I guess, makes up the majority of presentations of metastatic breast cancer. There is also a group that makes up a smaller number of people where they've never had a diagnosis of early breast cancer. In fact, their first diagnosis was with advanced disease. And we call them, I guess, a de novo presentation. And so it might be picked up on scans when someone presents with a breast lump and they're being sort of investigated prior to establishing the treatment for that early breast cancer, that in fact that it has spread to other parts of the body. It tends to be more common in triple negative breast cancer or HER2 positive breast cancer. And I guess one thing to say is that because you've not ever had any treatment for breast cancer before, it means that there's more treatment options available and on the table because the cancer hasn't proven itself to be resistant to them. By the same token, if it is recurrent disease, then often people will have had treatments before, and that needs to be considered when thinking about what treatments might be appropriate. And I guess a common question when someone is diagnosed with advanced breast cancer is, well, why didn't the initial treatment that I've had work? If it were the case that they had had early breast cancer previously. And I guess, unfortunately, drug treatments that we offer are not universally successful at eliminating rogue cells that might have escaped. Or sometimes cancer cells can get into parts of the body where the drugs don't reach. And one example of that is the drugs that we use may not get into the brain or the central nervous system very effectively. And so we call that sort of their sanctuary sites. And an example is that in HER2 positive breast cancer, recurrence in the brain is more common than in, for example, HER2 negative breast cancers because of that the drugs like Herceptin don't necessarily get into the brain that well. And sometimes, unfortunately, the treatments that we give in early breast cancer are not, they might cause side effects that mean that need to be stopped early, and so therefore treatment might be less optimal, which might increase the chances of recurrence in the future. So when we talk about systemic treatment, we're talking really about drugs. So I tell people that I'm the drug guy, and that it's really about giving medicines that go throughout the body. So we mean systemic as being going throughout the body, and therefore treating cancers wherever they might be. The drugs that we use will vary according to the specific type of breast cancer. So It's not just chemotherapy, it's not just hormone blocking treatment or what we call endocrine therapy, but it's newer treatments that might target specific aspects of the cancer, specific proteins on the outside of the cancer cells, called monoclonal antibodies or tyrosine kinase inhibitors. So these are newer treatments that have sort of really emerged in the past 10 to 15 years. An exciting group of drugs are what are called antibody drug conjugates, where it's actually pairing a traditional chemotherapy with a newer type of targeted therapy in the one molecule, and they're clever in that they use the chemotherapy is using the targeted therapy as like a Trojan horse to get into the cell. So those drugs are more specific to the cancer, tend to cause less collateral side effects. Of course, in advanced breast cancer, other treatments like radiotherapy and surgery may still also be important, as well as what we call supportive care, which is managing side effects of treatment or symptoms associated with the cancer. And like in early breast cancer, it's very important that we distinguish between the different subtypes of breast cancer in advanced or metastatic disease, because that really directs the way that we treat it. So the subtypes of breast cancer are determined by these receptors on the outside of the cell, so the HER2 receptor and the hormone receptors for estrogen and progesterone. So whether these cells are present or absent will determine whether this is a triple negative cancer where none of those receptors are present, a HER2 positive where the HER2 receptor is present in large numbers, or a hormonal one where it's got the hormone receptors but it doesn't have the HER2 receptor in large numbers. And so then our treatment is directed at the individual subtype. So today I've sort of divided it up into triple negative metastatic disease, HER2 positive, and then hormone receptor positive, HER2 negative. So to begin with triple negative breast cancer, metastatic breast cancer, what I've done is, I guess, just to provide a bit of an overview of standard treatment, not in any detail, and then just a little bit about newer treatments that are emerging, becoming available. And so, and this is not projecting very well, but I guess for patients that are just diagnosed with metastatic triple negative breast cancer, then the standard treatment nowadays is with chemotherapy, and then what you unfortunately cannot see here is immunotherapy. So immunotherapy may be useful in combination with chemotherapy if the cancer has a particular protein on the outside called the PD-L1 receptor. If it doesn't have the PD-L1 receptor, then increasingly we're using combination chemotherapy with platinum-based drugs, so a drug like carboplatin in combination with drugs like taxanes or gemcitabine. Down the bottom here it says PARP inhibitor, and PARP inhibitors are a type of targeted treatment that is useful in patients that have a BRCA mutation, a BRCA1 or 2. Now, the reason that they were in a different colour, which is not projected, is because those drugs are not available on the PBS. So yes, they are available, but unfortunately they're very expensive. So immunotherapy, for example, they have had programs to access drugs like pembrolizumab, but usually it's at a cost of around about $60,000 for a course of treatment or more. Similarly, olaparib, which is a type of PARP inhibitor, yes, it's available, but it costs around about $6,500 a month. So often, of course, these things we have evidence that they're effective and that there is a role for them for some years, unfortunately, before we see these drugs subsidised on the PBS. And so, yes, it's exciting that new things are coming along, but there's often a lag, which is very frustrating in terms of being able to access these drugs. We still have traditional chemotherapies that can be used for triple-negative breast cancer, like capecitabine, eribulin. Then we have, this is an example, it's called sacituzumab or sacituzumab govitecan, also known by the trade name Trodelvy, which is an example of one of these drug antibody conjugates. So it's actually an antibody that latches onto a different protein on the surface of triple-negative breast cancer cells called TROP2. So it's in this slide here. So this molecule called TROP2, it latches onto that molecule, and then attached, you can see these little red dots diagrammatically, is a chemotherapy molecule. So it's actually using the antibody to latch onto the cell, then it's going into the cell, and then releasing off the chemotherapy to specifically launch an attack inside the cell. So that's a sort of, I guess, a more modern strategy in treating advanced breast cancer, this drug antibody conjugate. And so this was demonstrated to be effective in triple-negative breast cancer in the second-line setting or beyond. And the research was published a couple of years ago, and then through a lot of campaigning, the drug has been on the PBS since the 1st of May for women with, or men with triple-negative breast cancer in the second-line setting onwards. So this is an example of, I guess, where things are emerging that provide hope in, I guess, an area where really chemotherapies have been it for a long while. So new antibody drug conjugates are being studied in clinical trials. This is just one example that has made its way onto the PBS, but new ones are coming, and this is really just an example. I mentioned olaparib. It is relevant for women with BRCA mutations, with metastatic triple-negative breast cancer, or indeed hormonal breast cancers where the person has a BRCA mutation, not yet PBS listed. And then I mentioned immunotherapy, so a drug like pembrolizumab. There's another one called atezolizumab. Now what they do, they're drugs which are they're designed to expose cancer cells to the body's own immune system. So usually our immune system can recognise cancer cells as being foreign, but then the sort of secondary checkpoint in the immune system says, oh, hang on, no, actually that's come from the body, so let's leave that alone. What these drugs do is stop that second checkpoint from happening. So actually it allows the immune system to say, hey, this is a bad cell, let's get rid of it. They're very expensive drugs. They've only been around for about a decade, and really it's only really just in the last few years that breast cancer has been an area that the companies have focused on to try and target. And there is good evidence that they're effective in the population of triple-negative patients where there is this receptor called the PD-L1 receptor, but very prohibitively expensive. So we really just have to keep on finding more evidence so that we can lobby the government to make these accessible for everyone. So I guess we've got their drug antibody conjugates, targeted therapies like olaparib, and immunotherapy coming along, so that it's really not just chemotherapy that's the only strategy we have for triple-negative metastatic breast cancer. Now to HER2-positive disease, and again, there's sort of the exciting new and emerging bits are not projecting very well here, but I guess for sort of 5 or 6 years we've had evidence that adding a drug called pertuzumab or Perjeta improves outcomes for women with metastatic HER2-positive disease in the first-line setting. It's given in combination with Herceptin and a type of taxane chemotherapy. What's exciting is that we now have more drugs coming through in the second-line setting. So when those treatments stop working, there's a drug called TDM1 or Kadcyla, which is another example of that Trojan horse drug antibody conjugate. So it's using trastuzumab or Herceptin as the Trojan horse to get the chemotherapy emtansine into the cell. And that has been a big advance, and that drug's been around for 4 or 5 years on the PBS, maybe longer. We have a new drug which is called trastuzumab deruxtecan, which goes by the name TDXD or Enhertu. That is not yet approved in the second-line setting, but the results for that drug compared with TDM1 are very impressive and control the disease for much longer than TDM1, and there's a very, very high response rates. So that drug will become available on the PBS. I have no doubt about that. It's just a matter of when, not if. It is becoming available in some clinical trials or what are called access programs just in the last month or two around Australia. So if you are in this situation, we'll then ask your oncologist about this drug Enhertu and whether it's appropriate for you and how they can get hold of it, because there are ways. Although, granted, and I'll come to this later, that obviously accessibility in Tasmania is an issue, and I'm in the middle of Sydney where you can access things more readily, but I acknowledge that it is a problem. I guess in the third line setting, then we've got a drug called tucatinib, which you can't see there either, but I will move on to the next slide. So tucatinib is another type of targeted therapy, and the thing about tucatinib that is quite important is, I mentioned before that sometimes drugs don't get into the brain very well because of this thing called the blood-brain barrier that stops chemicals from getting into your central nervous system. Tucatinib actually gets through there, and so it's been a really good drug for patients that actually have brain metastases, because often we've relied on surgery and radiotherapy to treat brain metastases. We now are working on drugs that are able to find their way in there, so that it's not just radiotherapy or surgery that we need to rely on. And tucatinib has been shown to be really effective, not just in women with brain metastases, but in women with other sites of disease. And it's used in combination with a drug called capecitabine, along with trastuzumab or Herceptin. And so that is still, unfortunately, not available on the PBS. Again, very expensive drug, difficult to access at the moment. I haven't been able to access that for a patient, but soon enough we will be able to. So these things are on the horizon, not necessarily available yet. And then I mentioned this drug, Enhertu or trastuzumab deruxtecan. So again, using that antibody to sneak the chemotherapy inside the cell to sort of deliver the chemotherapy payload more specifically. And so just as an example here, you can see that in terms of, after 12 months on treatment with this drug, 75% of patients had their disease still under control, versus the standard, which is Kadcyla or TDM1, only 34%. So quite a big difference. And so I think as they refine their technology with these drug antibody conjugates, we'll get more and more impressive results. Of course, everything that we do as oncologists causes side effects, but a part of coming up with new drugs is also coming up with drugs that cause less side effects, not just more effective. We're also looking at the role of immunotherapy in HER2-positive disease. There is a trial that's currently recruiting in Hobart called the Diamond trial for women with metastatic HER2-positive disease, which is using immunotherapies called I can never say it actually, what's written there, plus tremelimumab, in combination with Herceptin, so that combination of drugs has no chemotherapy. So to see if that actually provides benefit. And so that's a trial that's being run by Breast Cancer Trials, which is a Australia-wide and New Zealand body, that one of the trial sites is in Hobart, so it's being recruited to there. They're also looking to see whether in HER2-positive disease that has a hormonal component, whether using drugs called CDK inhibitors have a role. That trial has completed, but we're still waiting for the results to emerge there. And speaking of CDK inhibitors, I now move on to hormone receptor positive, HER2 negative metastatic breast cancer. And CDK inhibitors have emerged in the past 5 or 6 years as being sort of really successful treatments in the first-line setting for women with this type of advanced breast cancer. And it's shown now in clinical trials that these drugs have extended survival on average, or the median survival, by at least 12 months, which for a new drug to add 12 months is a big deal when that median survival times are not as long as we would hope they are. So to add 12 months on with a new drug is a step forward. They are now available on the PBS in combination with standard old friends like anastrozole or letrozole or fulvestrant. We also have, again, not projecting, the PARP inhibitors do have a role for patients with BRCA mutations, and then a drug called Palliative, which I'll talk about in a second. You've still got chemotherapy options for hormone receptor positive disease, but I guess what's changed is that we're trying to push those further and further down the line, so that we're using hormonal strategies first because they tend to have less side effects before we have to move to chemotherapy. And so the CDK inhibitors have really extended the time that women can be on treatments that are not chemotherapy, which has been a huge step forward. So the CDK inhibitors are ribociclib, palbociclib, abemaciclib. They're all available on the PBS now in the first-line setting. 2 of those are available in combination with fulvestrant, which some of you might know as Faslodex. And it essentially doubles the amount of time before the cancer progresses, so that before that treatment stops working. So it used to be that just giving, say, letrozole, the cancer would be controlled for, on average, 12 months. Adding these drugs extended the average out to 2 years, but with a big variation. I've got some patients on these treatments who have been on first-line treatment for over 5 years who still haven't progressed. So these are being a big advance. They're tablets, they're not chemotherapy. That requires less visits. Been a big step forward. Fulvestrant, it's been around for a while, but it's actually only just been put on the PBS. And that's because it's come off patent. And there's now a generic version made by Sandoz, which is obviously much cheaper to produce and cheaper for the government to subsidise. And so that's now available either to give on its own or have as a treatment on its own, or in combination with one of the CDK inhibitors that I've mentioned. It is injections in one in each backside every month, which is a bit unpleasant. But it's sort of extending again those hormonal options before people need to move on to chemotherapy. And then we've got new targeted treatments. So this is one example of where a drug has been developed that specifically targets another mutation or protein within the cancer. So this is looking beyond estrogen receptor or HER2 receptor and looking for mutations within the cancer cells. And this drug, which is a tablet called Palliative, targets a mutation called the PI3 kinase mutation. And that's about 40% of patients. It's given in combination with the injection fulvestrant. And that's currently, we know that it's better than just giving fulvestrant on its own in this group of patients, but it's now being looked at to say, well, what is the place, when should we give it? Should we give it as the third line or the second line? Should we give it before or after a drug called capecitabine? There's a study that's being run by Breast Cancer Trials called the CAPTURE trial, which I'm running in Sydney at the site where I work, but is also recruiting in Hobart. So these are for patients where they've had CDK inhibitors in the first line setting, And they've stopped working, and it's looking to see whether alpelisib plus fulvestrant is better than capecitabine. So that's an option of a trial that's being run, a national trial that's being run locally, looking at and potentially being able to access that drug, which again is not yet PBS listed. Also looking at a host of other possible treatments, what are called oral SERDs. So fulvestrant is a SERD, which stands for selective estrogen receptor downregulator. You'll have to trust me on that. It's given as an injection. No one likes an injection. These are trying to develop those drugs in tablet form that are equally as effective. And there's a few different studies going on with different drug companies' molecules looking at whether they're effective. Type of drugs called AKT inhibitors, which again are a targeted treatment, looking at sort of one of the pathways downstream from the estrogen receptor in the cells, again given in combination with fulvestrant. And then something really exciting is that a couple of weeks ago at the main sort of annual oncology conference in Chicago, there's a trial that was presented with this drug that I mentioned in HER2-positive breast cancer called Enhertu or TDXD, which has actually been shown to be helpful in patients with hormone receptor-positive HER2-negative disease, because it's actually useful even if there's only a few number of the HER2 receptors. It might not be enough HER2 receptors on the outside of the cell to be called HER2 positive, but it actually works if there's only a few. And so that's opened up a whole potential treatment option for patients with hormone receptor positive disease that might have what's called HER2 low. Very exciting. This drug has shown sort of huge promise in HER2 positive breast cancer. Now we've got an example where it's actually being used in hormone receptor positive disease. It's, these drug antibody conjugates, I think, are really a way that we'll see things improve for metastatic breast cancer. The only way things really improve is by running clinical trials. And I know that in Tasmania, the access to clinical trials, I guess, is an issue in that there's only so many trials that can be run locally. To run a clinical trial and to be across a clinical trial as an oncologist involves quite a bit of time. And so normally at any one time, as an oncologist, if you're involved in clinical trials, you might only have sort of a dozen or less that you are recruiting to. And so often, I guess across Australia, there'll be clinical trials that are being run at sort of a handful of sites, and they're often spread out, and unfortunately, not all the time will Tasmania be one of those sites. But look, I guess I would say that there's still a role of clinical trials and to consider those, to look and see what's available locally, and just to, I guess, think more broadly and to see whether it is possible for you to be involved in a clinical trial that might be further afield. I guess I'm probably just about out of time, am I, Ricky?
A few more minutes.
Okay, in that case I'll go back. But clinical trials, there's a range of clinical trials, and there's what we call different phases. And so every drug starts out in what's called a preclinical phase, which is not up here, which is essentially when you're testing it on cells in a lab or on mice. It's only then when you demonstrate that the drug might have some merit that you move to human trials, and then the first trials that might be what are called phase 1 trials. And they're often done in a very small number of people, trying to establish that the actual drug is safe to give. So often being involved in a phase 1 trial, there's not a huge promise that that drug might be helpful for you as an individual, but it's determining whether that drug's safe to progress in the next phase. Sometimes those drugs do prove to be very effective, and indeed all of those new drugs that I've mentioned started out in phase 1 trials. Phase 1 trials are often not the thing that you would reach for first. So it wouldn't be that you, in the first line setting, would opt for a phase 1 trial on an untested drug, but they might be something that you consider if other treatments have not been successful and that you're sort of looking at, what's available to you. Phase 2 trials are when they're done in a larger number of patients, often a few hundred, and that's really again to just establish, that they're safe, that they're effective, and to try and work out what the right dose is. It's only in phase 3 trials that we really determine that a drug is successful and that would lead to it becoming approved by like the TGA and then ultimately end up on the PBS. And they're often trials that are done in hundreds or thousands of patients, usually big studies that are conducted around the world. Phase 4 trials are actually often done after a drug has proven to be successful, and phase 4 trials are often called pre-registration studies, and that's when a company is trying to, let's say a drug is approved overseas, but the Australian government says, we want you to provide more data to show that this is safe and effective and cost effective for Australian women, Australian patients. And so they might conduct a trial just in Australia saying, you can access this drug, we're just going to study it a bit more closely and look at the side effects and see that what the way that Australian oncologists are going to use this drug is the same as what the trial says. So then we can say to the government, hey, you better list this drug. And so often they're a way in which patients can access drugs that are proven to be effective but are not yet available. There are lots of benefit to participating in clinical trials. Because they're very rigid, the protocols, then it makes sure that all the clinicians involved in your care are doing things by the book. So the care is as per the standard and best evidence-based care. So everyone, regardless of whether they're on the drug that's being tested or the standard treatment, will receive at minimum the highest standard of care. You also get, this can be a downside. People say, I don't want to see you every week, Ben. Well, you are seeing people more often, and that can be a benefit because if you're being seen by doctors and nurses and so forth more often, then they might pick things up more quickly. So that can actually be beneficial for some people. For some people, it can be a disincentive. We know that whenever you have people monitoring you more closely, you tend to do better anyway, somehow. It's like, if I make sure I go to the gym with a personal trainer, I'm more likely to do it than if I do it at home. That's actually true. So, look, I think that potentially clinical trials are a way to access treatments that are not yet available on the PBS. I guess also it's about thinking, the way that all of these treatments have become available is people like yourselves having been prepared to put their hand up in the past to take part in clinical trials to advance the cause. I think, certainly being part of a clinical trial can mean changing the team that are looking after you. When you've got used to a particular individual or particular people, to then have to go somewhere else and be part of a clinical trial. If you're looked after here in Launceston and then you were being treated in Hobart, for example, that can be a bit jarring. But we understand that and try and work with people and accommodate that and understand that that can be anxiety provoking or a degree of uncertainty. Often investigations need to be performed more frequently on clinical trials. There's less flexibility about when you have treatment. If you want to go on a holiday, for example, that's not necessarily all the time though. There's still room to move. And then lots of challenges, I guess, sometimes in terms of meeting the particular criteria that the trial is sort of looking for, the particular group of patients. Are all your blood test parameters where they need to be to participate and so forth. So Breast Cancer Trials is a national body that runs trials specifically for breast cancer, and these are just 3 examples of trials that are running for metastatic patients in Australia. Now, these are actually the only 3 that are being run by BCT at the moment, but there are dozens of other trials that are being run outside of BCT. So BCT is not the only place running clinical trials in Australia. So every site that runs clinical trials might have half a dozen trials in breast cancer that they're running at a particular time that fall outside of the umbrella of breast cancer trials. But of the 3 that are being run for metastatic disease, 2 of them are recruiting in Tasmania. So it's not the case that Tasmania doesn't have any access to clinical trials. And that's all I'm going to talk about right now.